بسم الله. بسم الله. بسم الله. بسم الله.
Assalamu alaikum. I would like to welcome you all in this workshop. This is Batoul Muhammad, clinical pharmacist, board certified infectious disease pharmacist from Al-Musa Specialist Hospital. In this workshop, inshallah, we will discuss the challenges of implementing antimicrobial stewardship program, especially in the critical care areas. Okay. Sorry. Sorry, just give me a few minutes just to solve this technical issue. Sorry for the interruption. Great. So let's start our workshop with this survey. So please scan this barcode to start answering the questions. Okay, so our first question is, are you implementing antimicrobial stewardship program in your hospital? Yes or no? So great. About almost, okay, more than 90% are implementing ASB in their hospital. Okay, so 80%. Okay, who's the champion on your ASB program? Is it the pharmacy, ID doctors, or hospital administration? Okay, great, ID doctors. So about 60% of the attendees, the IDs are the one who's leading the ASB. Okay, excellent. And then what strategy are you implementing in your hospital? Is it pre-authorization, prospective audit and feedback, or both of them? Yeah, so most of the attendees are using both strategies. Okay. So what were the greatest challenges that you faced while implementing ASB, especially in the ICUs? Can you please share with us? Any answers? MDROs. Okay. So you mean managing MDROs? Administration support. This is really important. Shortage of staff. Worried of de-escalation. So doctors, let's say behavior or compliance, acceptance. Okay. Restriction, which is the mainly pre-authorization strategies are. Was and teamwork. Oh, no ASB. Okay. With these challenges, we will start our workshops. Actually, ICUs is an appropriate focus of the ASB team, as that most of the IV antibiotics being, and especially the broad spectrum antibiotics being given in the critical care areas. And also in the critical care areas, it is the focus of many patients with life-threatening multi-drug resistance organisms, bacteria. Okay, ASB must work with the ICU team to ensure rapid delivery of effective antibiotics, especially for the critically ill patients, and intensivists also must work with the ASB team to tailor or stop antibiotics when indicated. So from the literature, the main 4 challenges were addressed are lack of awareness, local clinical practice customs, lack of interdepartmental coordination, and lack of specialized ASB technologies or tools. Starting with the first challenge, about making awareness on public level and healthcare provider level. So in fact, only 40% of the general population are aware about the proper usage of and resistance. And more than 50% of the clinicians reported lack of awareness of ASB program and its components. Okay, with this challenge, let's start our first activity. Please discuss with your group 2 strategies either you implemented or you want to implement to improve the awareness of antimicrobial resistance and use of antimicrobials. So please take 10 minutes to share with us 2 strategies. Choose 1 speaker in the group to talk about 2 strategies to be used or used to improve the awareness of antimicrobials usage and resistance. I will lead on better. كنت أفضل كذا يعني صراحة. المايك شغال. شغال. Okay. 5 minutes. 5 minutes. 5 minutes. So, can we start? Yalla. Group number 1, could you please share with us at least one strategy to improve awareness?
Okay, so my name is Dr. Mohamed Bakkar from KFMMC, Khobar. Okay, in regards to antimicrobial resistance for the public, so an emphasis on education, like educating the masses on what is antimicrobial resistance and the prevalence and incidence of it. And then number 2, the restriction of antibiotic prescription, which is already implemented in our healthcare system. Those are 2 points to mention. I'll leave room for the others to mention. But for the optimal use of antimicrobials in the healthcare setting, number 1 is referring back to your local antibiogram is very crucial, and educating the healthcare workers and the staff about what is the local antibiogram at the facility. And comparing it to the region or other hospitals is very beneficial for the institute as a whole.
Exactly.
And number 2 is restricting the antibiotic and as part of the ASP and reviewing.
That would be a part of implementation, as you said, yes.
And then another point we're mentioning that to have the pharmacy also play a part in the role in making decision of discharge, medication counseling, and reconciliation.
Excellent.
So those are
Thank you.
brief thoughts.
Should I just go through your points to discuss, if you don't mind, please? The antibiotic restricted, or the antibiotics restricted there in your own area. Where do you go work? Where do you work? So the restricted antibiotics there is based on your own antibiogram or a list of the Ministry of Health or your ministry that you go through. How do you restrict antibiotics?
Thank you for your question. Regarding the restriction of antimicrobial, we are following the MSD, Minister of Defense, classification of antimicrobials. So we have 3 layers of antimicrobial classification, actually 4, 1 without restriction and 3 with restrictions, level 1 and level 1A, level 2A and level 2B. So every classification has to go for certain policy and review. For the level 2P, which is the absolute restricted antimicrobials, it should be approved by ID consultant. And level 2A, it should be reviewed by the ID consultant over the next working hours, over the night. If it's started by any consultant, that's fine, and it should be reviewed. And regarding the level 1, it should be reviewed by the pharmacist also, and periodically, maybe 2 times per week, for the whole patients who are on those kind of antimicrobials.
Thank you, Kat. Group 2.
Okay. Do you have one strategy at least to share? Yes.
Okay, I am Dr. Jumana Samaha, infectious disease consultant from AL-AHSA Hospital. For the antimicrobial resistance, as previously also mentioned, we have to make awareness about the local antibiogram of our hospital and the importance of the policy of restriction and pre-authorization. The restriction, so we are applying our policy for three groups of antimicrobials. Restricted are not dispensed by the pharmacy except after approval of the ID, monitored approval of the clinical pharmacist. And the restricted should also be reviewed by the clinical pharmacist. And the third is the permitted. Now the optimal use of antimicrobials, maybe the guidelines, we should update them regularly according also to the antibiogram.
Thank you, thank you.
Just to add something, I think also we actually started this in our hospital. We start to restrict the privilege to the ID consultant for some antimicrobials, valuable antibiotics like the novel beta-lactams, ceftazidime, and Zerbaxa. So it could be helpful point.
Exactly, to control the prescribing behavior mainly.
What?
So, to control the prescribing behavior mainly.
Yes.
Exactly, yes. Yes. Can we get the last strategy?
Good afternoon. So in our group, I'm one of the infection control nurse in National Guard AL-AHSA. So to promote awareness for the antimicrobial resistance, the group suggested to incorporate the antibiogram in the daily rounds especially for the physicians, in which they are the one responsible to do the prescriptions. We can explain to them how the antibiogram works. Because mostly, to be honest, in our facility, it's very, very rare. Only those who are rotating in infectious disease, those are the one who are really knows how to deal with the antibiogram. So that's one of the awareness strategy. And the second one, also, that's part of the education and the compliance to the guidelines. So whenever we have these residence trainings or even the link nurses, we can incorporate our policies and procedures and what are the guidelines that we use about antimicrobial resistance. But actually this compliance to the guidelines is both antimicrobial resistance and optimal use of antimicrobials. So the second strategy to promote awareness regarding the optimal use of antimicrobials is ASP Awareness Week, or basically it's a part of education, wherein you have to do educational programs for the patient, for the healthcare workers, regarding the proper use of antimicrobials.
Okay, yes. So starting from the public level, regular public awareness campaigns would really help about raising the public awareness about antimicrobial usage and current resistant status. And on the healthcare provider levels, conducting regular training and educational sessions for the healthcare providers, starting from the physicians, educating them about the proper diagnostic methods and proper management, establishing the guidelines for them to follow would really help in your implementation of ASP program. Moving to the nurses and educating them about the proper administration of antimicrobials and including the ASP education and the training and the competency, especially for the ICU practitioners, would really help in controlling using the antimicrobials. Moving to the second challenge, which is about local practice, clinical practice customs. Conformism, changing the prescriber behaviors about antimicrobials means taking into account factors that can influence their prescribing behavior on the department level and ward level and even facility level. So their prescribing could be influenced by many factors, starting from their fears, beliefs, access to antimicrobials. As you mentioned, all of you, restricting the access to the antibiotics will really help in controlling the antimicrobials. Also, access to the ASP team is really important, that the ASP team always on board and available on the rounds, on the daily rounds, so the doctors and nurses have easy access for them. And the used ASP strategy also is very important and can affect the prescribing behavior for the doctors. Okay, let's take also 5 minutes to discuss two strategies to improve the prescribing behavior. What did you do in your institution to improve the prescribing behavior of the doctors? Can you please discuss it with your groups?
Just take. Doctor?
Daily rounds with the ICU by the clinical pharmacist and infectious.
Exactly, including the clinical pharmacist and ID consultant in the daily rounds would really help in improving the prescribing behavior, as you said.
Doctor, open contribution. How do you let
Yeah, actually, one of the methods that we implemented at our facility is having a clinical pathway to infections. So even that makes the decision making, whether at the level
Easier
of the
for the
ER or at the primary health care or even as an internist, easier to follow the clinical pathway. And implementing even HIS system to give you recommendations or drug-to-drug interactions, interventions, for example, wrong dosing, all that I think is good to have.
any other?
Yeah.
Any contributions here?
Yes.
I think it should be a complete and complementary strategy, like teamwork, involving the primary care physicians and the internal medicine teams, the other teams also, and to have direct access to the ASP team, as you are telling. ASP team also should have, inside the team itself, it has to be a complementary work. Like, for example, as my colleague, our clinical pharmacist, Dr. Firas, tell, that they are reviewing some prescriptions for the level A restricted antibiotics.
Exactly.
Then, when they are detecting unaccepted behavior, they will inform the ID physician. We will initiate consultations. So there should be teamwork like this.
Exactly.
Also, how to make the ASP team very accessible. We implemented the strategy in our facility of ID on call 24 hours.
Exactly. That would really satisfy the intensivist.
Yes, sure. The intensivist, but also the other teams actually.
Exactly, yes.
Do you have a dedicated clinical pharmacist to be always there on time to review the antibiotics, or at least the restricted antibiotics, and to be in contact directly with the ID consultants in order to judge whether these antibiotics are there to be prescribed for the patient or not? I mean, let's have your actual life there in the hospital.
In our hospital, we have the chance to have a team of ID clinical pharmacists, actually. Or they are clinical pharmacists and they are with us.
So there is an on-call clinical pharmacist, like 24 hours?
They are not on call 24 hours, but whenever we ask them for something, they are
they are ready.
answering.
They are ready.
Yeah.
Good pharmacists.
They are eager to answer.
Thank you.
Thank you.
Any contributions?
Regarding your question about the on-call, actually, I'm working in Moasa Hospital, Dammam, and we have already on-call clinical pharmacist, actually. Moasa Hospital. And it's really helpful. If I'm in charge, for example, I receive many calls, actually, at home. They asking, they tell me about the case, and then I will ask, if the ID is not available, they will ask me about the proper choice, for example, the proper dose for the patient, and if we agree, then they will go with my choice.
Any other contributions?
Dr. Wafaa Al-Fahd, consultant clinical pharmacist, infectious disease, principal military medical city. Actually, in our institute, through the system, we have a notification, notify the clinical pharmacist or actually antimicrobial stewardship pharmacist regarding to the medication in regard with if there is an accurate dose or medication need dose adjustment or low level or even high toxic level. So this one, it will notify the pharmacist regarding to the medication. Comparing with the previous, the pharmacist have to review all the patient profile, and sometimes there is missing patients not reviewed. But with the system, so notification can catch all the patients who receive antibiotics, and it will alarm for any medications or for any patient has problem with the medication.
Good. Any other?
What we follow in our hospital in ICU is we have a team of ID, infection control.
Where do you work?
King Saud Medical City, Riyadh. So in ICU, we have a team of ID, clinical pharmacist, infection control. And we go all around ICU twice in a week as a team. And especially we target those cases or those patients in ICU who are on antibiotic but with negative cultures, and especially those who are newly admitted. So we see that not very high level of antibiotics are started before the culture results, and if it is started, they de-escalate it after the culture results, especially the empirical antibiotic that is used. Most of the times we see they use mostly they start with meropenem or colistin most of the times. So yes, they do that. So sometimes we try to de-escalate that. Based on the culture results as soon as it is available.
How do you share educating or instructing the prescribing physicians to
They
go
are
through?
involved
So your
in
ASP, as far as I have understood, that your ASP round is going to optimize, not to judge.
Yes.
Did you get my point? So
Yes.
I don't know whether Dr. Abatu would say, let's be there from the beginning, from the start, so we can be able to roll out with an X antibiotic with the exact or the right dose and right duration should be there, right?
Yes.
Optimizing sometimes will go after like 3 days or 4 days.
Yes.
The medication will be turned on from empiric to therapeutic. And what is the ASP role at this point? Did you get my point? All right. So when the medication or the antibiotic is prescribed empirically, and the empirical medication used based on the patient improvement, for example, the medication is being used for 5 days, and at this point of view, the ASP team has arrived there to say de-escalate or continue. Is it the right they have already came to? Or do they have to start with the round with the doctors from the beginning?
Because our ICU has multiple units, and everywhere the physician is different. So when we go to a particular
unit, not enough
unit,
staff of pharmacists or the ASP going there.
Yes.
You mean you can't catch up all the areas?
we choose patients because we go twice in a week, and when we go to a particular patient, we involve the physician handling this patient.
Could you specify the word particular?
Sorry?
Particular. When you go to a particular, do you have a specific group of infections or group of patients that you go through in order to look after the patient there? Or just randomly?
No. A day before we go for the rounds, the clinical pharmacist who is in the area, along with the ICU physician, they choose patients especially for the rounds. They choose patients to which the team will be visiting the next day.
Okay.
Okay, and they are from various units. It can be from surgical trauma, it can be through negative pressure rooms, you know. They choose patients from all over the ICUs or from all units of the ICU. And once they choose, in this also there are patients who are newly admitted, so that we tackle them from the beginning. So we go twice in a week, so we can you know, visit patients who were visited in last 2 days also.
Yeah. So you are going with the random auditing and feedback
Yes.
on the actual round with the IDs and intensivists, and that's great. And choosing which strategy to go with, it depends on the in the institution itself, on the antimicrobials itself. So we all agree that create guidelines to lead as a guidance for the intensivists, starting from the diagnosis to management and even monitoring of antibiotics is really critical to success your ASB program. Also restricting, yes, the antimicrobials. All of you agree that having a restricted list starting from ER approved antimicrobials and controlling the mostly expensive or with higher rate of consumption or higher of increasing rate of resistance, and classifying these antimicrobials into controlled, restricted, or limited usage antimicrobials. I will share with you, this is our list in the hospital. As an example, for it's controlling the usage of antimicrobials, we divided the antimicrobials into controlled, restricted, and limited based on the local consumption and local prescribing behavior and antibiogram. And using the right strategy for the right institution. It is not black or white, yani. Each strategy has its own advantages and disadvantages. Starting with the pre-authorization, it is very good to control targeted antibiotics. So it's very good to control the novel antimicrobials, costly antimicrobials. Also, it's highly effective for the early stages of ASB, and especially on the pandemics. Also, it will really help. Reducing the initiation of inappropriate antimicrobials. It will also reduce the cost for the hospital of antimicrobials. But it could affect the starting time of antimicrobials. Yes, it could delay the starting of antimicrobials. Also, usually the prescribers wouldn't like it. Yani. You're taking their autonomy, so you will have some troubles to convince the physicians about this strategy. Also, it could increase the risk of misusing other unrestricted antimicrobials. Like you are controlling the tazocine or controlling the meropenem, then the physicians will go to the tazocine or ceftriaxone. Also, it really needs 24/7 ASB team on call. Yeah, this is really important to not affect the patient safety. Also, the effectiveness of this strategy depends on approval skills. So you have to have really good skills to convince the prescriber about your rationale from changing or restricting the usage of that antimicrobials. For the auditing and feedback, it really gives an opportunity for education for the prescribers. Also, when you are doing auditing, you have a real good clinical data to build a recommendation. Also, it maintains the prescriber's autonomy. Also, the escalation and the duration of therapy can be addressed in this strategy. But it needs more time because and it needs an IT support so you have the access for the prescribed already antibiotics. So you need a report, you need an IT support to get that report and review it and give the feedback to the prescribers. Also, compliance is voluntary. So the antimicrobial is already ongoing. So you will review and you have to convince the prescriber about your recommendation. Success also depending on the feedbacks, how you are giving the feedback, how regular you are giving a feedback even for the prescribers and for the chairman of the ASP committee even. It will take a longer time to reduce the usage of targeted antimicrobials. Why? As I said, you need an IT support to target antimicrobials instead of doing random auditing. It will take a longer time to show that efficacy. So moving to the third challenge about interdepartmental coordination. Actually, yes, we have to admit that the intensivist has the multi-drug resistant organisms and life-threatening infectious conditions in the ICUs. The philosophical approach and priorities differ between the ASP team and the intensivist. He wants to save the life and he wants to give the antibiotics as soon as possible. And he wants, you as an ASP member, you don't want to overusing the antimicrobials because in the ICU setting. So do you have any approach or ideas to enhance the coordination between the critical care practitioners and ASP team? What do you think, Dr. Jumana?
Again, to give awareness more and more, because now you reminded me a few days ago, one doctor, he was telling me, I don't want the patient to go into septic shock. I told him, I don't want either, but do you want her to get MDR and it will be difficult to treat? So it's always to give awareness.
Yeah, be close to them, available and access to ASP team in the daily rounds, discussing the cases, with the doctors. Being around will really show them that you care about the patient and you know the whole situation. And you want to save the patient and, of course, the future of antimicrobials. So creating a specific ASP policy and protocols will really help to follow the ASP guidelines. Collective responsibility by including these physicians and intensivists in your ASP committee would really, you are sharing the responsibility with them and giving regular feedback for the prescribers. They want really to hear about your ASP. Are you getting any benefit, any outcomes? The MDROs increasing, decreasing? How's the resistance about the antimicrobials that you are holding away from us? Also, to ensure success of the ASP program, it's really important to include a senior executive leader champion. It's really important to have it in your, and I think most of you, yes, address that the support from the administration is critical to promote the implementation of the ASP program. So, accountability, education, hospital leadership, and the tracking, of course, all of them are core elements. You have to have them to success your ASP. So now I would leave the stage for Dr. Anas to talk about the ASP technologies and tools.
Okay, good afternoon, everyone. I'm Anas. I'm adult critical care clinical pharmacist and ASP pharmacist in Al-Mus Specialist Hospital. My part will be about the technological challenges that we see with the ASP daily work. Okay, so I will spare you all the studies and data and literature, and we'll talk just about pure experience. So, first of all, who, by show of hand only, who have a electronic medical record that they are using? Electronic medical record, health information system. Okay, by show of hands, who's using it? Who's still on paper? Half. Yes, that's it. We have a lot of hospitals still partially on paper. Okay, so the EMR is one of the cornerstones for the to facilitate the work of ASP team. We have the rapid diagnostic, measuring the metrics and the course and the skills of the IT department and the MID department. All of them are connected with each other. So we see that it's not one by one, all of them are connected. So anyone can tell me what's the program they are using in your hospital? HIS, the YASASI? Oh, HIS by name. Okay. Anyone else? What is the program they are using? Okay. Doctora, what is the electronic medical record system that you are using?
The CareWare.
CareWare?
Yes.
Okay. Okay. So,
I'm not sure of the name, maybe HIS. We call it HIS.
Okay. As a help. Anyway, we have a lot. From the most famous are the Cerner or the EPIC. We have in our hospital what we use the YASASI brand. So why the electronic medical record is important to us? How can it help us in the ASP daily work? Anyone can participate? How do you think, sorry, the voice is, okay, sorry. Okay, I'm asking how the electronic medical record can help you in the ASP work. Okay, Dr. Anwar? Retrieving the data, that's good, yes.
As the doctor there said, retrieving the data, for example, for doing MOEs, for example.
Okay, that's great. Doctora?
Patient history of infection disease and hospital history or hospital infection. For example, is there resistance for MRSA and what's related to that will be administered to the patient?
Okay, great. So overall, yes, doctor. You can take the mic, please. So the restriction part. Yes, great. Okay, Dr. Ahmed.
For the history of medication, past medication for the patient, even at home.
Okay.
So it can be linked between the medication once the patient admitted and what's the medication at home.
Okay.
It can also improve the way of communication.
History for a patient.
Improve the way of communication.
Yes.
Because the EMR will be facilities for all the physicians.
Sure. So we need to know one thing. The functionalities in each electronic medical record is different from one to one, and it's modifiable. That's a good thing. So the electronic medical record, you can introduce order sets, predefined order sets, to your electronic medical record. So once you have a patient, let's say, with VAP, okay, there is an order set for VAP based on the latest guidelines, and you will have this order set. This order set, you will put the specific antimicrobials, all the medication related, all the labs related. So it's in one place. There is no place for the physician just to go whatever he wants. He will go with the guidelines. So we can introduce order sets to EMR. We can add compulsory indication entering. So the physician, once he wants to enter, let's say, antimicrobial, he should put why he's using the indication for this antimicrobial. He cannot proceed with the order without the indication. Hard stop or review dates. We face a lot of issues with antimicrobials that go beyond the days that let's say we need 7 days, and the patient 10 days or 11 days on it. We finish the 14 days and still it's going. So some electronic medical records, they have hard stop dates. You can integrate decision support system like Lexicomp. You can integrate Lexicomp to your electronic medical record So you will have the latest data with a decision support system for you. Once you will enter meropenem, let's say for sepsis, you will have a pop-up with the diagnosis, and you can just click it and open all this. We can do the restriction for antimicrobials, as the doctor said. Allergy alert linked to best practice, as we said, the decision support system. Even some systems that is integrated with ASP module, they can give you suggestion for IV to oral. Okay, and some systems, we can even document the ASP work through the system. No need for paperwork and tracking. Okay, so examples of the decision support system that you can integrate, the well-known lexicon. We have the antibiotics alert, antibiotic assistant. I think in the UK it's available. It will give you the correct antibiotic. It will cause the reduction in antibiotic usage. It will do reduction in broad-spectrum antibiotic usage, decrease the length of stay, reduction in adverse event, decrease mortality, and increase in pharmacy intervention, reduction in time spent from the antimicrobial stewardship team, and it will decrease the cost. And this is the most important issue that you will justify to the leadership or your hospital, that you want to bring a system that is costly, so you need to go with the cost effectiveness data. Even anyone using any decision support application on his phone, yes, related to antimicrobials, the well-known, yes, doctor.
It is prepared already for the ER, for the usage of antibiotic. For example, they will put in the symptoms and the lab result. It will tell them which, for example, tonsillitis or pneumonia.
Okay, that's great. Even on a lot of us is using the lexicon, some using the Sanford guide for the antimicrobials, the Johns Hopkins antimicrobials. So this is just a screen of a modification that we did in our own EMR. If you see, let's say this is a meropenem order. Whenever you prescribe an antimicrobial, automatically the other side, the laser is not working here, the other side will open below the dose. Okay, whenever you prescribe antimicrobial, you will have this mandatory field that you will fill. So anyone will prescribe antimicrobials, he have to choose either is this therapeutic or empirical, prophylactic or pre-op. Once he click any one of them, he will have a drop list. The drop list will give you either ID approved or based on culture or others. Whenever you see anything in pink, this means it's a mandatory field. So any physician that he will put others, he have to put a justification. Okay? So this way we are doing the pre-authorization step. According to the restriction, we have again the three lists that the doctor mentioned for the restricted antimicrobial, the controlled, and it will follow, and the pharmacy staff will follow the process of the restriction. Okay, so this is a modification that we did through our IT to do it in the system for all the antimicrobials. Anyone have any restriction in the electronic medical record in their system that can help us with? Okay, so this is just a small kind, how you can overcome a challenge like this in your electronic medical record. This is the integration of lexicon. It will be integrated to the system. The good thing about lexicon that you can even upload your own data.
The previous program done through the Access Microsoft Office or the application, the previous one.
Which one?
I mean that program.
This one,
Right.
yes.
This one, Access Microsoft Office or what?
Oh,
or the application?
No, this is the hospital electronic medical record. It's yes. So, but our IT guys, with the help of the company, they did the modification. So it was like a simple modification from IT point of view, but still it have a great impact on the daily practice. Okay, this is the order sets that I was mentioning before. Let's say this order set for sepsis. the physician will fill it is integrated in the HIS system, and you will just check all the boxes that you need, okay? It's all based on evidence-based medicine on the right side, and he will just check the boxes that he needs. It will decrease the time used for the ordering, instead of ordering for images, labs, medication, nursing instruction. It will be in one place, and he will just save it, and it will distribute in the system everywhere. So this is for the electronic medical record that we are saying. Rapid diagnostics. Anyone have in his hospital rapid diagnostic testing for antimicrobials? Malditoff. Good. Anybody else? Yes.
For us, we have also multiplex PCR.
Multiplex PCR. That's great. Anybody else is using any rapid diagnostic testing in his hospital? Okay. The rapid diagnostics, it's let's say we have many rapid diagnostic, even starting from the screening of the patients, just the regular MRSA screening, CRE screening, VRE screening, that is done, reaching to the Malditoff or the multiplex PCR or all the other new diagnostics, and it's climbing up with the price. So if you have the Malditoff or the multiplex, it's a huge cost, but it can be justified, okay? I just did this comparison between the available, not the only available, but this is the most common that we deal with, the Malditoff MS, the BioFire, which is the multiplex PCR, Virogene, and the T2 Candida and bacterial identification. Anyone can tell me how we can use rapid diagnostics to improve our ASP work? And why it will affect positively our daily work with ASP?
It will quicken optimize the use of antibiotic. It will reduce the use of the random use of antibiotics, so we do not really rely on the empiric.
Exactly. Yes, as Dr. Anwar said, we will decrease the time for the empirical antimicrobial. We can have very rapid identification of the bacteria, and even we are saving lives. If you have a patient like a septic shock patient in the ICU, and you start your empirical antimicrobial, then after 3 or 4 days till you get the finalization of the culture, and you are missing the bacteria that you want, especially if we didn't start the proper antimicrobials at the beginning. Also, we are sparing the use of big guns, like if you have a patient, according to your antibiogram, that coming with septic shock, you will start, let's say, like meropenem with amikacid or meropenem with colistin plus gram-positive coverage with a vancomycin. You will follow with levels. You may get nephrotoxicity. These tests can give you results within 1 hour. So the Malditoff will give you the result with less than 0.25 hour per isolate. Okay, the multiplex PCR will give it in 1 to 2 hours, the result, in comparison to like 3 days of waiting for the cultures. The Virogene will give it in less than 2.5 hours, and the T2 Candida or the bacteria 3 to 5 hours, which is still a very good time in comparison to the regular culture. Let's say we can go to the specification, like each one of them. So the Malditoff, this is a new technique that it's a mass spectroscopy in an analytical technique whereby samples are ionized and produce a mass spectroscopy. It's like a fingerprint for each bacteria. The Malditoff, they have more than 1,000 species that they can identify within like 10 to 15 minutes. Okay? The pros for this, it has sensitivity and specificity of 98 to 100%, and it can shorten time to pathogen identification and decrease length of stay, recurrent infections and mortality. And as we said, it have more than 1,000 species. But cons for this, it will not show you the resistant genes. So it will give you that this patient has Pseudomonas, but you don't know what resistant genes is there. And it cannot be used for polymicrobial culture because it will give you only one isolate. It will take time till you do the subculture. And there is no library available for unusual organisms, but they keep updating their database. The problem with MALDI-TOF, you need the culture to grow first, like a blood culture. You have a growth, then you can take a sample from it and do the testing. The multiplex PCR, the BioFire, they have many panels. They have the blood panel, the pneumonia panel, meningitis panel, the GI panel. It's a novel multiplex PCR real-time assay. It has sensitivity and specificity 90 to 100%. It don't need subculture. This is the great point. You have a patient admitted to ICU with signs of septic shock. You can take the sample and immediately put it, and within 1 to 2 hours you will get the identification. It has very good bacterial and viral and some yeast coverage. It can show you the resistant genes. Not all of them, but a very good amount of resistant genes. So you can take a decision for patient within instead of 3 days or 5 days for the final identification. There is no study regarding the clinical effect of the multiplex PCR implementation so far. If anyone interested, this is the blood culture panel and what it can detect. And this is all the updated resistant genes that they can detect. Anyone has used the multiplex before? Okay. This is the pneumonia panel. You can just send the tracheal aspirate. Within an hour to 2, you will get the result. This is the GI panel. This is the meningitis panel. Once you draw a CSF, you just send it, or a stool culture for the GI. The other technique, but it's not available here, and it has some limitations, which is the Verigene. It's a direct detection positive blood culture medium using nanotechnology particles. It has very good sensitivity and specificity. It's the most developed commercially available product for resistant genes, and it can detect resistant genes, but the problem that it only detects 9 gram positives and 4 gram negatives only. So this is the limitation for this expensive with limited use. So if I don't have the luxury to the MALDI-TOF or multiplex PCR, we have something like cheaper, which is the ChromaGar. The ChromaGar, it's a microbiological media used to identify different microorganisms by color production. So growth media use enzyme substrate that release color dyes on hydrolysis with a wide range of enzymes that can be targeted. You will have a plate, and it will give you the color for specific type of bacteria. It has very good sensitivity and specificity. It can detect polymicrobial growth, especially like tracheal aspirates. It can detect some resistant genes. The cons for this longer time to identification is like the regular culturing or on the plate. Different manufacturers with different colors for this identification, so you need a skilled microbiologist to know which is which. Anyone came through the ChromaGar before? Do we have any microbiologists with us here? Okay. This is the like example of the plates, what you will see. Okay, so if we have the multiplex PCR, the MALDI-TOF, we have the regular identification. How we can speed up the process? Anyone can help us to overcome this challenge? I don't have multiplex PCR or MALDI, so I have the regular Phoenix PD or with the microscan or whatever that we are using. So if I don't want to wait for the 3 and 4 days of identification, or if I have a later grower, like I need 5 days of culturing, anyone can suggest anything to speed up the process instead of keeping the patient on empirical antimicrobial for 3 to 4 days, and maybe I'm missing. Microscopy result. Okay, can you elaborate a little on this? Yes.
You have to consider.
I'll give you the mic now, Doctor, but Doctor will answer here.
Based on the microscopy of the sample that was sent, whether it is gram positive or gram negative, at least gives you the preliminary idea of what can be the organism which can help you in choosing the antibiotic.
Okay, that's great. Yes, Doctor?
In addition to that, we have to consider the risk factor I mean, we can read the deep about the patient condition, method in the past, what's the age. Yeah, you can get a good idea
Great.
about
You will
it.
put like any recent hospital admission if
Yeah.
he's colonized in other hospital or in your institute with the previous multi-drug resistant bacteria or something like this. Anyone else want to add anything? Rapid antigen testing. Yes. Okay, one of our daily work, what we do, and we found that it will increase the regular biochemical testing in the microlab. If you will send a culture, you will have a positive blood culture in the incubator after 24 hours, then they will take the sample, they will put it on agar plate, we'll wait another 24 hours.
Healthcare, hence the most C preparatory
certified. We are committed
in preparation receiving for their
follow
require control.
Whatever. Okay, and you will wait for the identification. Okay, once you get a result from the microlab that you have a gram-negative bacilli, that's great. This gives you the first indication that it's a gram-negative, not a gram-positive. So if I'm having my patient in, let's say he started on vancomycin, meropenem, colistin, and he looks like he's improving, he don't have a history of recent admission, he don't have a screening for MRSA that he's colonized with, I can, in some cases, drop the vancomycin from day one. Okay, what about this gram-negative? Using the biochemical testing, the regular biochemical testing, I think it's available in almost all the microbiology labs. It's a cheap reagent that we use for the identification. But if you contact the microlab early, you went to the microlab, asked them, okay, I have this gram-negative bacilli. What does it look like on the plate? Even the form of the colonies, and the microbiologist can give you. He's telling me, oh, it looks like Klebsiella. It smells like Pseudomonas. Okay, is it lactose fermenter or non-fermenter? If it's a fermenter, I'm thinking about Enterobacteriaceae. So I know that my culture, it could be Klebsiella or E. coli. Okay, how much I have CRE in my hospital to be afraid that this could be Klebsiella, but CRE, if I'm afraid of resistance, you will go back to antibiogram data for previous admissions or the patient if he has anything. Oh, he's telling me, no, it's non-lactose fermenter. Okay, can you run for me the oxidase test? He will run for you the oxidase test. This will take minutes. Oxidase positive, I'm thinking about Pseudomonas. Oxidase negative, I'm thinking about others. Let's go to gram-positives, the same. I will run on the cocci, I will run the catalase testing. If it's positive or negative, then I will go, is this catalase, is it coagulase negative or positive? Once I'm sure that I'm having a coagulase negative, I will be relieved, okay? So this is on daily work, we do it like daily with the microlab. It will help you to reduce the time on the antimicrobials, the unnecessary use of the antimicrobials. Okay, measuring the metrics. How can the electronic medical record help us with the metrics? We said that we can retrieve a lot of data from the electronic medical record with the help of our IT. The most common metrics that we collect is the DDD, DOT, some others like IV to oral, switching, the length of stay, the mortality, the length of therapy. Like in UK, they depend on length of therapy instead of days of therapy. So they will calculate for how many, they will calculate the full courses of the antimicrobials. We can calculate the resistance rate, the antibiogram. Many hospitals now, they have the live antibiogram data on their website. The microbiological data will be integrated immediately to the website and you will have it live. So you don't need to wait till the end of the year to collect the data for the whole year and go, you have it live. The C. diff rate. So if you have an electronic medical record, you just need you need a skilled IT staff to help you with generating the reports that you need to meet your requirement. Again, what if I don't have IT staff, I don't have the system by itself? You can do your interventions on a sheet, like an access sheet. This is an example of an access sheet that we use in our hospital. This is our intervention data sheet that we will collect in an access database, and we will generate data from it. So this is only the intervention part. Whenever the ID is rounding, we will collect the on daily basis, and we will fill it. You can go back to the supply chain data for the consumption of antimicrobials. You can check with the quality department in your hospital. It can give you the mortality number of the mortality cases, and you can discuss anything related to sepsis or to infections in general. You can initiate KPIs to follow. Let's say how many of us face that we have a patient, we do a urine analysis and culture, we have a positive culture with a negative urine analysis, and it's treated. So do the opposite. Check a urine analysis. Don't make it a standard to do a culture. Make an analysis. Once you have a positive analysis, you will go to the culture. You can run a KPI in your hospital to do this and decrease the number of urine cultures done and treated colonization, not even UTIs. So as we said, UTI, pneumonia, or you can do it if you don't have the enough stuff to targeted antimicrobial. You can, let's say, follow, I want to target the colistin, and I want to see the use of colistin all over the hospital, and you can do a KPI on targeted antimicrobials of concern. The cost is the main issue in this stuff. Anything in new technology, you need a lot of money for this. To get the approval for this, first of all, you need the leadership support. This is one thing. You need feasibility studies. Like, if I want to introduce the multiplex PCR and the cost of this is 500,000 riyals, I need to do a feasibility study to see that this is effective. How much I'm saving antimicrobials, how much it's affecting the resistance rate, how much it's affecting the mortality, and even one of the good things that you can outsource your service. Instead of doing it to your own, you can sell it to others around you. Not all the hospitals around you will have this technology. So the outsourcing is one of the things that you can do with these new technologies. For sure, collecting the data with the cost effectiveness to the leadership will improve the situation for the ASP team to ask for new diagnostics or improvement in the electronic medical record that you have. The incentive program, Dr. Abatul, she mentioned that you should have a champion, either a physician, a pharmacist, microbiologist, technician. Anyone can be a champion, the ASP. So the incentive program will motivate people more and more to do this. And just some words, some antibiotic stewards is better than none. So even you are small with the ASP now, it will improve. Just keep working on it, okay? You have to teach early and often, as Dr. Anwar said, the continuous education, because education has a half-life of a beta-lactam. So you need to keep doing the education, and the ASP steer the ship, but we need all hands on the deck to complete the journey together. Thank you very much. Any participation or input from anyone?
Thank you very much for this amazing presentation, all of the speaker. I just have a concern regarding the molecular test, the multiplex PCR. The multiplex PCR is very useful tools for antimicrobial escalation when it's used for screening. Like for screening of MRSA, it's beneficial for the escalation, the growing evidence for the CRE screening. Also for the sterile site, like meningeal panel, for example, and blood. Although all the multiplex PCR for the blood will need culture still. But I have concern regarding how to balance between stewardship and multiplex PCR from non-sterile site, like for example the lower pneumonia panel. So now it have been utilized more in the hospital, so patient in ICU, it will turn positive for BCR, for Acinetobacter or for Klebsiella. This will confuse, I think, the ICU physician and the ID more. So how we can balance between?
Okay, thank you, doctor. With the multiplex PCR, I think as the restriction of the antimicrobial, we should have a very strict restriction to diagnostics. the one who asked for these diagnostics, either the MALDI-TOF or the multiplex PCR, it should be the ID physician. It should not be with any other physician. Okay, so the ID, he will give you that, the order just to check for this one. The other problem, as you mentioned, especially the tracheal aspirate, is the polymicrobes. We have patients like have 3 or 4 bugs in the tracheal aspirate, and you don't know which one is the culprit. The multiplex will show all of them. So yes, it is one of the obstacles, but again, if you do the testing with the recommendation of the ID consultant, and it's not open, because it's expensive test. The multiplex PCR, I think a cost price of 300 or 400 riyals is the cost price of each test. So it's not a cheap test that you can throw it here and there. So again, the diagnostics need restriction. Thank you. Okay, thank you very much. Thank you for attending.
Please stay in the room. In a few minutes, we will have the recognition for the workshop speaker and moderator, and also the CIC certification. So just we are waiting for the other group of workshop to finish. هذا ولا
اي على اساس ما يطلع.
In AL-AHSA Specialist Hospital, our #1 priority is patient safety. Our commitment as a provider of healthcare has always been to best quality and minimizing the infection as possible. Infection prevention and control is a universal healthcare issue that knows no boundaries. Hence, the demand for certification in infection prevention and control, CIC, continues to grow as a necessity for health and safety in the dynamic healthcare sector. CIC is the most advanced certification in the field of infection prevention, which gives you a sense of professional accomplishment and international recognition. Join our unique CIC preparatory course to attain your certification and prove that you are an infection prevention hero.
Our aim is to increase the number of certified infection preventionists in Saudi Arabia as well as the Middle East in order to improve their qualifications and to enhance the standards of infection prevention and control.
We are committed to provide you with the highest quality of education and to prepare you with the best resources to prepare for the CIC certification.
In addition to the best study resources and the amazing preparation experience, this course is rewarding as you will get a chance to be reimbursed for the registration fees as well as the exam fees if you fulfill the requirements. Enrolled applicants receive a weekly progress report with motivation to reach certification. Moreover, all newly certified IPs will be invited to our annual infection control conference and recognized for their achievements.
Being certified in infection control CIC can help your career in multiple ways. It proves your credibility. It provides you with personal satisfaction. It helps you in lowering the infection rates in your institution and promote the safety environment in your hospital.
I found this is a unique course because it consists of in-house studying followed by online studying group with follow-up on weekly basis for the outcome and the progress.
By the end of this course, the applicants will be able to fulfill CBIC online examination requirements and apply easily for the certification exam. The below competencies will be extensively addressed. Fundamental concepts of epidemiology and microbiology. Fundamentals of infection control practices in healthcare organizations. Examination content for infectious diseases, surveillance, preventing and controlling the transmission of infectious agents, occupational health, management, communication, research, cleaning, disinfection, sterilization and the environment of care. Problem-solving skills for infection prevention and control. Requirements for CIC exam and preparation strategies.
We got huge sources and exercise questions. We received great guidance from our course instructors and leaders of discussion.
Join our unique CIC preparatory course to attain your certification and prove that you are an infection prevention hero. In Al-Musa Specialist Hospital, our #1 priority is patient safety. Our commitment as a provider of healthcare has always been to best quality and minimizing the infection as possible. Infection prevention and control is a universal healthcare issue that knows no boundaries. Hence, the demand for certification in infection prevention and control, CIC, continues to grow as a necessity for health and safety in the dynamic healthcare sector. CIC is the most advanced certification in the field of infection prevention, which gives you a sense of professional accomplishment and international recognition. Join our unique CIC preparatory course to attain your certification and prove that you are an infection prevention hero.
Our aim is to increase the number of certified infection preventionists in Saudi Arabia as well as the Middle East in order to improve their qualifications and to enhance the standards of infection prevention and control.
We are committed to provide you with the highest quality of education and to prepare you with the best resources to prepare for the CIC certification.
In addition to the best study resources and the amazing preparation experience, this course is rewarding as you will get a chance to be reimbursed for the registration fees as well as the exam fees if you fulfill the requirements. Enrolled applicants receive a weekly progress report with motivation to reach certification. Moreover, all newly certified IPs will be invited to our annual infection control conference and recognized for their achievements.
Being certified in infection control CIC can help your career in multiple ways. It proves your credibility. It provides you with personal satisfaction. It helps you in lowering the infection rates in your institution and promote the safety environment in your hospital.
I found this is a unique course because it consists of in-house studying followed by online studying group with the follow-up on weekly basis for the outcome and the progress.
By the end of this course, the applicants will be able to fulfill CBIC online examination requirements and apply easily for the certification exam. The below competencies will be extensively addressed. Fundamental concepts of epidemiology and microbiology. Fundamentals of infection control practices in healthcare organizations. Examination content for infectious diseases, surveillance, preventing and controlling the transmission of infectious agents, occupational health, management, communication, research, cleaning, disinfection, sterilization and the environment of care. Problem-solving skills for infection prevention and control. Requirements for CIC exam and preparation strategies.
We got huge sources and exercise questions. We received great guidance from our course instructors and leaders of discussion.
Join our unique CIC preparatory course to attain your certification and prove that you are an infection prevention hero. In AL-AHSA Specialist Hospital, control is a universal healthcare issue that knows no boundaries. Hence, the demand for certification in infection prevention and control, CIC, continues to grow as a necessity for health and safety in the dynamic healthcare sector. CIC is the most advanced certification in the field of infection prevention, which gives you a sense of professional accomplishment and international recognition. Join our unique CIC preparatory course to attain your certification and prove that you are an infection prevention hero.
Our aim is to increase the number of certified infection preventionists in Saudi Arabia as well as the Middle East in order to improve their qualifications and to enhance the standards of infection prevention and control.
We are committed to provide you with the highest quality of education and to prepare you with the best resources to prepare for the CIC certification.
In addition to the best study resources and the amazing preparation experience, this course is rewarding as you will get a chance to be reimbursed for the registration fees as well as the exam fees if you fulfill the requirements. Enrolled applicants receive a weekly progress report with motivation to reach certification. Moreover, all newly certified IPs will be invited to our annual infection control conference and recognized for their achievements.
Being certified in infection control CIC can help your career in multiple ways. It proves your credibility. It provides you with personal satisfaction. It helps you in lowering the infection rates in your institution and promote the safety environment in your hospital.
I found this is a unique course because it consists of in-house studying followed by online studying group with the follow-up on weekly basis for the outcome and the progress.
By the end of this course, the applicants will be able to fulfill CBIC online examination requirements and apply easily for the certification exam. The below competencies will be extensively addressed. Fundamental concepts of epidemiology and microbiology. Fundamentals of infection control practices in healthcare organizations. Examination content for infectious diseases, surveillance, preventing and controlling the transmission of infectious agents, occupational health, management, communication, research, cleaning, disinfection, sterilization and the environment of care. Problem-solving skills for infection prevention and control. Requirements for CIC exam and preparation strategies.
We got huge sources and exercise questions. We received great guidance from our course instructors and leaders of discussion.
Join our unique CIC preparatory course to attain your certification and prove that you are an infection prevention hero. In AL-AHSA Specialist Hospital, our #1 priority is patient safety. Our commitment as a provider of healthcare has always been to best quality and minimizing the infection as possible. Infection prevention and control is a universal healthcare issue that knows no boundaries. Hence, the demand for certification in infection prevention and control, CIC, continues to grow as a necessity for health and safety in the dynamic healthcare sector. CIC is the most advanced certification in the field of infection prevention, which gives you a sense of professional accomplishment and international recognition. Join our unique CIC preparatory course to attain your certification and prove that you are an infection prevention hero.
Our aim is to increase the number of certified infection preventionists in Saudi Arabia as well as the Middle East in order to improve their qualifications and to enhance the standards of infection prevention and control.
We are committed to provide you with the highest quality of education and to prepare you with the best resources to prepare for the CIC certification.
In addition to the best study resources and the amazing preparation experience, this course is rewarding as you will get a chance to be reimbursed for the registration fees as well as the exam fees if you fulfill the requirements. Enrolled applicants receive a weekly progress report with motivation to reach certification. Moreover, all newly certified IPs will be invited to our annual infection control conference and recognized for their achievements.
Being certified in infection control CIC can help your career in multiple ways. It proves your credibility. It provides you with personal satisfaction. It helps you in lowering the infection rates in your institution and promote the safety environment in your hospital.
I found it a unique course because it consists of in-house studying followed by online studying group with the follow-up on weekly basis for the outcome and the progress.
By the end of this course, the applicants will be able to fulfill CBIC online examination requirements and apply easily for the certification exam. The below competencies will be extensively addressed. Fundamental concepts of epidemiology and microbiology. Fundamentals of infection control practices in healthcare organizations. Examination content for infectious diseases, surveillance, preventing and controlling the transmission of infectious agents, occupational health, management, communication, disinfection, sterilization and the environment of care. Problem-solving skills for infection prevention and control. Requirements for CIC exam and preparation strategies.
We got huge sources and exercise questions. We received great guidance from our course instructors and leaders of discussion.
Join our unique CIC preparatory course to attain your certification and prove that you are an infection prevention hero. In AL-AHSA Specialist Hospital, our #1 priority is patient safety. Our commitment as a provider of healthcare has always been best quality and minimizing the infection as possible. Infection prevention and control is a universal healthcare issue that knows no boundaries. Hence, the demand for certification in infection prevention and control, CIC, continues to grow as a necessity for health and safety in the dynamic healthcare sector. CIC is the most advanced certification in the field of infection prevention, which gives you a sense of professional accomplishment and international recognition. Join our unique CIC preparatory course to attain your certification and prove that you are an infection prevention hero.
Our aim is to increase the number of certified infection preventionists in Saudi Arabia as well as the Middle East in order to improve their qualifications and to enhance the of infection prevention and control.
We are committed to provide you with the highest quality of education, prepare you with the best resources to prepare for the CIC certification.
In addition to the best study resources and the amazing preparation experience, this course is rewarding. You will get a chance to be reimbursed for the registration fees as well as the exam fee if you fulfill the requirements. Enrolled applicants receive a weekly progress report with motivation to reach certification. IPs will be invited to our annual infection control conference and recognized for their achievements.
Certified in infection control CIC can help your career in multiple ways. It proves your credibility. It provides you with personal satisfaction. It helps you in lowering the infection rates in your institution and promote the safety environment in your hospital.
I found this is a unique course because it consists of in-house studying followed by online studying group with follow-up on weekly basis for the outcome and the progress.
By the end of this course, the applicants will be able to meet the online examination requirements and apply easily for the certification exam. The below competencies will be extensively addressed. Fundamental concepts of epidemiology and microbiology. Fundamentals of infection control practices in healthcare organizations. Examination content for infectious diseases, surveillance, preventing and controlling the transmission of infectious agents, occupational health, management, communication, research, cleaning, disinfection, sterilization and the environment of care. Problem-solving skills for infection prevention and control. Requirements for CIC exam and preparation strategies.
We got huge sources and exercise questions. We received great guidance from our course instructors and leaders of discussion.
Join our unique CIC preparatory course to attain your certification and prove that you are an infection prevention hero. In AL-AHSA Specialist Hospital, our #1 priority is patient safety. Our commitment as a provider of healthcare has always been to best quality and minimizing the infection as possible. Infection prevention and control is a universal healthcare issue that knows no boundaries. Hence, the demand for certification in infection prevention and control, CIC, continues to grow as a necessity for health and safety in the dynamic healthcare sector. CIC is the most advanced certification in the field of infection prevention, which gives you a sense of professional accomplishment and international recognition. Join our unique CIC preparatory course to attain your certification and prove that you are an infection prevention hero.
Our aim is to increase the number of certified infection preventionists in Saudi Arabia as well as the Middle East in order to improve their qualifications and to enhance the standards of infection prevention and control.
We are committed to provide you with the highest quality of education and to prepare you with the best resources to prepare for the CIC certification.
In addition to the best study resources and the amazing preparation experience, this course is rewarding as you will get a chance to be reimbursed for the registration fees as well as the exam fees if you fulfill the requirements. Enrolled applicants receive a weekly progress report with motivation to reach certification. Moreover, all newly certified IPs will be invited to our annual infection control conference and recognized for their achievements.
Being certified in infection control CIC can help your career in multiple ways. It proves your credibility. It provides you with personal satisfaction. It helps you in lowering the infection rates in your institution and promote a safety environment in your hospital.
I found this is a unique course because it consists of in-house studying followed by online studying group with follow-up on weekly basis for the outcome progress.
By the end of this course, the applicants will be able to fulfill CBIC online exam requirements and apply easily for the certification exam. The below competencies will be extensively addressed. Fundamental concepts of epidemiology and microbiology. Fundamentals of infection control practices in healthcare organizations. Examination content for infectious diseases, surveillance, preventing and controlling infectious agents, occupational health, management, communication, research, cleaning, disinfection, sterilization and the environment of care. Problem skills for infection prevention and control. Requirements for CIC exam and preparation strategies.
We got huge sources and exercise questions. We received great guidance from our course instructors and leaders of discussion.
Join our unique CIC preparatory course to attain your certification and prove that you are an infection prevention hero.
Assalamu alaikum. We are waiting our colleagues to join us for the recognition of CIC members. The time they will join, we will start the ceremonies. But for the meantime, we would like also you come to the stage, our CIC members, and let's take a picture together. So please welcome to the stage, and inshallah the next group when joined, we will make it the ceremonies again. Dr. Nazia, Dr. Hanadi, Amal, Dr. Bilaji, and waiting the list. Mr. Ibrahim, can you put the list? So as you know, and by the leadership of Al-Musa Hospital and part of their responsibility to prevent infection, we conduct and promote for CIC certifications. Good. For CIC certification, today we are delighted to see you, our CIC members here. You know, the CIC need a lot of commitment and studies, and we are happy that you are here. You came from far places, and part of our responsibility to acknowledge your efforts here today. So inshallah, you come, and other groups, they will join. Inshallah, Dr. Zainab also, she will join us. You will get your prize, as I promised you, the CIC band certificates. So please come to the stage, all of you. The list is long, so we are waiting for the remaining members. Welcome, Bindu. I hope I did not drop any name because it's my moment and I drop a name. National Guard Hospital, still they are here. If they are here, please welcome to the stage. So, okay. Can you please come to us?
your own hospital, every day there is some to tackle that situation confidently. You should have some knowledge, and if you have knowledge, and if you have an education or if you have a certification, you know that makes you more dependable. People trust your decision.
and share with us his experience and the role of leaders in the promoting for certification.
Good afternoon, all of you. I know it's very few heads remaining. First of all, thank you to the institution to give us this chance to get on the stage. I'd like to be very focused on my talk here. The collaboration between AL-AHSA and the MOH, it started like way back in 2017 when I and Mahar used to discuss with Basil and Dr. Zainab and her team. It was amazing. I mean, to start with, we were very small, and now the people are getting CIC. I only wish this partnership will benefit from this. It's an opportunity to cash on. Resources are available, experts are available, and many are capable of getting this, but not many attempt to do that. So I wish all of wish the education and training attempts being taken up by this academy grows further. Okay, thank you and all the best.
So now we will, as we are reaching the closing ceremony of this conference, we will start now by recognition of the moderator of the workshop. So first, I would like to call Dr. Anwar. I would like to call Dr. Anwar Musallim for the workshop identifying overcome challenge in antimicrobial stewardship.
like to thank those. I would like to thank you for staying so late. Thank you very much. And I would like to thank our dedicated organizing committee, Dr. Reem, Dr. Abdullah, Mara, and the whole team for their great work. Thanks to Dr. Reem. Thanks to everyone who have shared with us today. And thanks to our moderators in the workshop. Inshallah, we'll see you, inshallah, in 1 year. Mark your calendar for the next, inshallah, AIDME conference. We'll see you, inshallah, next time. And thank you very much. Have a nice weekend. Have a safe trip if you're traveling outside AL-AHSA. Assalamu alaikum wa rahmatullah.